Hello, and good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh, and very good morning. So today, we are going to have another session on breakfast at UMHealth, which usually been held every Wednesday morning. And today morning, we only have one presentation from the Department of Obstetric and Gynaecology. And we are honored to have Dr. Farah Muhammad Faiz, who is the lecturer and a clinical specialist in our department, who has joined us many years back, and now currently in the department as a lecturer. And she will be speaking in this breakfast at UMHealth on menopause beyond the hot flushes. So, without further ado, we would like to invite Dr. Farah to share her presentation and continue with the talk. Thank you very much. Over to you, Farah.
All right, so good morning, everybody. My name is Farah. I'm from the Department of Obstetrics and Gynaecology. And today I'll be speaking on the topic of menopause. So this is something closer to us than we may realize, because I'm sure we all know someone who is going through menopause. We have cared for women who is experiencing menopause, and we may even be navigating this journey ourselves. So why this topic is very important is because women spend over 1/3 of their lives during this postmenopausal stage. So the average age of menopause is about 50 years, while the life expectancy is about 78 years. So by calculation, women spend over 25 years of their life navigating through this stage. The symptoms are often underreported by women themselves, and as healthcare professionals, we often under-recognize these symptoms. But during the menopausal stage, the risk of cardiovascular diseases, osteoporosis, metabolic syndrome, these are all raised, which all have long-term impact on women's quality of life and women's health. So as healthcare professionals, if we fail to recognize the symptoms and this risk, it's actually a missed opportunity for prevention and early intervention. So by the end of this session, I hope we can recognize menopause as a multi-system condition. I hope we have learned to identify the less obvious symptoms, recognize the hidden impact, the long-term implication, and all in all, support women more holistically. So just some introduction. By definition, menopause is the permanent cessation of menstruation resulting from loss of ovarian follicular activity. But in simple words, it just means no periods for 12 months. Now, before menopause, they go through perimenopause, which is the time when there are hormonal, biological, and clinical features begin. During this stage, hot flushes are really just the tip of the iceberg. Unfortunately, a lot of the discussion stops here. Now, when we think menopausal symptoms, the most obvious symptoms that we think of is hot flushes and sweating. This is actually termed the vasomotor symptoms. It affects a majority of women, more than 50%. It can disrupt sleep, causing fatigue. It disrupts work performance, and overall, it disrupts the women's quality of life. But this is not the full story. So I'd like to discuss I think of the symptoms as more of an iceberg concept. What's usually visible to us are the vasomotor symptoms, hot flushes, night sweats. But what's hidden are the risk and other symptoms such as genitourinary symptoms, cognitive decline, cardiovascular risk, bone loss, metabolic changes, and mood disturbances. So I'd like to discuss a hypothetical case, someone we might know, somebody we might have worked with. So Dr. X, she's 52 years old. She's got occasional hot flushes, but on the background, she's got poor sleep, she's fatigued, she's often forgetful, and she has low mood. In the last 2 years, she's put on some weight, and while she does not speak about it, she avoids intimacy due to discomfort. So the hot flushes are something that we will very obviously attribute to menopause. However, symptoms such as poor sleep, fatigue, forgetfulness, low mood, weight gain, and discomfort during intimacy, these are more vague symptoms which are usually attributed to just normal aging. But if we think about it, beyond the vasomotor symptoms, she likely has psychological symptoms, metabolic changes, early cardiovascular risk, and genitourinary symptoms of menopause. So let's speak on these symptoms one by one. With cardiovascular risk, when there is estrogen decline, there is endothelial and lipid dysfunction, which all increases your risk of cardiovascular disease. This is a leading cause of death in women. And what's more worrisome is that in women, the presentation is often atypical. With the hormonal changes, there's also central weight gain, adiposity, insulin resistance, which all increases your risk of developing diabetes, hypertension, and dyslipidemia. So menopause also affects bone health. With estrogen decline, there is accelerated bone loss, and research has shown that the risk of osteoporosis almost doubles during the postmenopausal stage. It's often silent until the patient presents with a fracture. Now, genitourinary symptoms are probably the most underreported, but has the highest impact on the women's quality of life. So this includes symptoms such as vaginal dryness, dyspareunia, urinary urgency, and recurrent urinary tract infections. So this has significant impact on self-esteem as well as the relationship. During the menopausal stage, women also undergo psychological and cognitive decline. They often go through anxiety, low mood, depression. They've got poor concentration, memory issues, and sleep disturbances. These are often attributed to stress or most of the time just missed entirely. Other symptoms include arthralgia, sarcopenia, and skin changes. Now, why are these symptoms often missed is because it's normalized as part of aging. Patients don't report them, and with symptoms like genitourinary symptoms and sexual issues, there is often a cultural silence surrounding this topic. Healthcare professionals also don't explore enough. So when we deal with patients with menopause, most of the time, a lot of focus is being put on the vasomotor symptoms, and we fail to explore into the other less obvious symptoms. So I'm going to speak generally on some clinical approach, and this should not only take place in the gynae clinic, but it should take place with whatever point of contact a healthcare professional has with a woman in the menopausal and the postmenopausal age group. History taking has to be more holistic. So beyond the chief complaint and what the patient came to the hospital for, we should attempt to explore more into the vasomotor symptoms, mental health, mood, sleep, genitourinary symptoms, sexual health. We should take this as an opportunity to perform cardiovascular and metabolic risk factor screening. So some of the screening that we can perform is blood pressure, BMI, waist circumference. We can send blood investigations for lipids, diabetes screening, FBC, RP, LFT. We should screen for bone health. We can perform breast cancer and cervical cancer screening. Management principles when it comes to women with menopause is that care has to be individualized. Different women have different symptoms with different severity, different background risk factors, and more importantly, they have different wishes and preferences. For every management option that we choose, there should be a risk-benefit approach, and the focus should be on prevention and early detection. We should not wait until the symptoms are debilitating enough or disrupting their quality of life so significantly. And oftentimes, this involves a multidisciplinary management. So before prescribing pharmacological management, we always start with lifestyle modification. So the 6 pillars of lifestyle medicine, we'll start with nutrition. So we always advise for a balanced, healthy nutrition. On top of that, we would advise for vitamin D and calcium supplementation. With physical activities, they have been shown to improve cardiovascular health, bone health, and boost mood. So what is recommended is moderate to intense exercises for 30 minutes for at least 5 days a week. They should have restorative quality sleep. We encourage patients to build social connections as this helps with the mood. They need to learn to manage the stress and avoid harmful substances such as alcohol, drugs, and smoking. Now, if this is insufficient to treat the symptoms, then we discuss menopausal hormonal therapy. So this was previously known as hormonal replacement therapy, and now we call it MHT. So these are most effective for patients who are symptomatic. They provide symptom relief, bone protection, and generally improve quality of life. The best candidates to receive MHT are those at less than 60 years of age or within 10 years since they attained menopause. So we should start early, intervene early, because this is the window of opportunity to treat the symptoms. With MHT, treatment has to be tailored. So risk stratification is very important, not just when starting, but there should be a regular interval to re-stratify the risk. So just a few examples of what we take into consideration when starting MHT. If a patient has a uterus still, which means it hasn't been surgically removed, estrogen replacement therapy is insufficient and they should have progestogen added. If the woman is at increased risk of venous thromboembolism, then we would consider non-oral routes such as spray, gel, or patch. Now, if the woman is at risk of breast cancer, then natural progestogens have a better safety profile compared to synthetic progestogens. Now, with any MHG that is started, we should have a regular review to assess the response to treatment, to re-stratify her risk, and they should have yearly breast ultrasound, 2 yearly mammogram, and 2 yearly bone scan to assess treatment response. This is just an overall view of the different types of MHT that we can prescribe. So for women who are already menopausal and no longer have bleeding, we prescribe the continuous therapy, which means estrogen and progestogen is administered daily for the whole month. Whereas for women in the perimenopausal phase, where they still have irregular bleeding, then we give them sequential therapy, which means that while they receive estrogen therapy daily, progestogen is only added on the first half of the month, and they're expected to bleed sometime during the second half of the month. These are just examples of the different type of oral and non-oral examples of estrogen, progestogen. And as I've mentioned before, we have the natural form and the synthetic form. For women who are not keen or not fit to receive hormonal options, then we also have non-hormonal options, depending on what is the most prominent symptom, whether it's vasomotor symptoms, genitourinary symptoms, or sleep. With discussion of herbal therapies and supplements, while there are a lot of options being sold in pharmacies, there are actually limited evidence to prove their efficacy in women who are symptomatic. Now, beyond all the pharmacological treatment, what's very important is the support we offer to these women. Workplace awareness is very important because many women who are struggling with menopausal symptoms still have their regular jobs. We should validate and acknowledge the symptoms, have open conversations surrounding this topic, and once detected to have symptoms or risk factors, we should intervene early. Now, going back to Dr. X, let's just revisit. She had hot flushes, poor sleep, fatigue, forgetfulness, low mood, weight gain, and vaginal dryness. So the best management for her would be lifestyle modification, vaginal estrogen to help with the vaginal dryness. And if lifestyle modification is insufficient, we would consider the use of MHT. And most definitely, she needs a cardiovascular risk assessment. So my take-home message from this is that menopause is more than just the vasomotor symptoms. It has multi-system impact with major long-term risks such as cardiovascular diseases, metabolic diseases, and osteoporosis. And with early recognition, it always results in better outcomes for the women. So the two very common guidelines that we use in the treatment and management of women with menopause is our Malaysian CPG, as well as the International Menopausal Society recommendations, which has just been released. Now, let's help women not just cope, but thrive through menopause. So in our gynecology clinic, we have a dedicated menopause clinic once a month where we manage all women through the perimenopause and the menopausal phase, both with pharmacological and non-pharmacological management. So if you know of anyone, or if you have a patient that's navigating through this journey, feel free to refer them to us. Thank you.
Okay, thank you, Farah, for the the presentation. So I think we are open to for discussion, and for those who have any question, please do type in the chat so that I can read it for you, and then we can ask Dr. Farah to help on to answer the question. Okay, so Farah, so a lot of your presentation just now, maybe you can unshare your screen. So a lot of your presentation actually pertaining to menopause who are already natural menopause. What about uh, those who are already prematurely menopause? So it's not yet supposed to be menopause, and they actually prematurely menopause. How would you manage that? Can you unshare your screen? Is it still in your desktop? Please unshare everything.
Just a moment, Prof. I'm not sure how.
Go to Zoom back, you, and then you. Okay, so you are unchecked. So there's a Q&A box where you can type in, or you can actually, I don't have the Q&A box here, but oh yes, there is. Okay, so can you answer the first question from.
Okay, from Prof. Okay, so before going through natural menopause, women may go through menopause at a younger age. This may be premature, or this may be due to surgical menopause, which means she's had to undergo oophorectomy for whatever reason. So if they have had to go through this stage prematurely, while they may not complain of symptoms, it's still very important to start them on MHT to provide protection for bone health and cardiovascular risk factors, as well as metabolic risk factors, as what's been discussed earlier. So if you know anyone who has gone through premature ovarian insufficiency, which means they've stopped having their period before the age of 40, or before at any time before the natural age of menopause, which I've discussed earlier, 49 to 50 years old, they should have the discussion of starting menopausal hormonal therapy for protection from what's been discussed earlier.
Okay, so it's really important. To make the audience know that the menopause is not only reach when you reach 49, 50, then only you have menopause, but some of our patients are prematurely menopause, where they actually need more attention, right, Farah? Because
Yeah.
they are the number of years without the hormone are actually longer compared to those who have natural menopause. So we have one question from a few questions now. So Prof YK actually asked, do men display the similar symptoms equivalent to the menopause that has been described by you?
I'm actually not too sure about the hormonal changes in men, bro.
Okay. Maybe we can ask Prof. Ong or Prof. Those who are urologists who can actually answer the thing. But I think I do read some of the articles that men also have their andropause, which actually exhibit the same symptom like what you have described. Okay. So there's one question from Diana. So saya Liza dari Jabatan Perubatan Molekul berumur 49 years old. Period terakhir saya pada 6/3 2026. Boleh saya merujuk Gynae? Terima kasih.
Of course, Prof. So we have a dedicated menopausal clinic every fourth week of the month. Maybe Puan Liza could leave your details, like your email, and I will reach out to you after this session.
Okay, so we do have a dedicated menopause clinic now. So it is not so many, but it's dedicated where we follow up like Farah said. It actually not exclusively for MHT, but it's also for non-pharmacological, pharmacological, and surgical treatment for patient with menopause. So there's one question here, doctor. How long would you advise MHT therapy for one when for one's commenced. Once it's commenced, how long can you advise to
Yeah, okay. So
continue?
the best time to start is, as I mentioned earlier, within the 10 years from menopause or less than the age of 60. Now, once started, there is actually no black and white saying what is the maximum duration that it can be continued. But what is very important is that at least annually, we need to re-stratify the risk and see whether continuing would cause higher risk than the benefits that it's providing.
So no
So
no.
there isn't actually a maximal duration to continue the MHD.
Mm. Okay. So any advice how we can explore the menopausal symptom with our patients? How do you explore menopausal symptom with your patient? How do you normally explore to them?
Okay. So for patients that are directly referred for them for the menopausal symptoms, that's much easier. But I think it's important that as healthcare professionals, beyond whatever they come in with their chief complaint, we should also ask how things are. Questions like how does she sleep at night? Does she feel fatigued throughout the day? How are her relationships with her spouse, with the children, with the friends? Is she exercising? Does she feel like she's got low energy throughout the day? Questions like that, Prof.
Okay. Do you have a certain like tick boxes like a form where the scoring is high enough for you to start, or is it very subjective?
Um, I I'm not sure if there's any cutoff score to start, Prof, but we have the self-assessment tool for menopausal symptoms for which we can know the severity of the symptoms that the woman is facing. And then from there, we balance with the risk and benefit, and then we decide to start the MHD after discussion with the woman.
Okay, there's one more question here. Hi, Dr. Farah. What is your opinion on starting Primarine cream for a breast cancer survivor?
Okay, so this is actually proven to be safe if your most prominent symptom is the genitourinary symptoms, which means things like vaginal dryness, recurrent UTIs. Starting local Primarine, which means the Primarine cream for local use at the vagina, is actually safe for breast cancer survivors.
Okay. And what if MHT has never been started in postmenopausal women? Any benefit? Asymptomatic. Maybe asymptomatic menopause women. Is there any benefit just to start the MHT?
Um, so it has been so this I'm assuming we're discussing for women still within the 10 years from menopause and less than age of 60 because this is the window of opportunity to start treatment. So if even if they're asymptomatic, it provides benefit in terms of cardiovascular and bone health. But beyond the age of 60, and if let's say you are more than 10 years from the time of menopause, then it's not actually been shown to offer more benefit compared to the risk for starting at that age.
So will you start for an asymptomatic patient? No,
Uh,
no symptom, normal bone health.
if she's already post-menopausal, then probably no. If let's say she's already at the natural age of menopause.
Okay. All right. So, doctor, should we do further investigation for to or consider perimenopause state for this patient, 48 to 49 years old, presented with irregular menses, sometimes prolonged menses, sometimes spotting menses?
Yeah, so this is probably termed the perimenopause stage, but aside from screening for cardiovascular and metabolic diseases, if she's got risk factors, we don't have to send further investigations such as hormonal profile to confirm whether or not she's in the perimenopause stage. Because even sending for these hormonal profiles, it would not change our management.
So, in other words, do you need a biochemical confirmation for all menopause women?
No, we don't.
Okay. So we don't necessarily take the FSH, LH, okay, for those who are already menopause.
Perimenopause or menopause.
Correct. Okay, any other question? We still got 4 minutes to take some questions. And Farah, how about postmenopausal women who came for bleeding? So what do you think that is the when it's already all ruled out? Would you think that you still can give a patient with MHT, or you won't actually give?
Okay, so with bleeding during the postmenopausal phase, we of course have to rule out the more morbid things such as endometrial hyperplasia, malignancy. But once everything else has been ruled out, more often than not, it's usually atrophic vaginitis or the atrophic endometrium that's causing some bleeding. So with that, the local Premarin has actually shown to be beneficial in helping with the symptoms. Of course, again, with regular assessment of treatment response and whether she later on develops any risk factors.
Okay. So I think everyone here in the audience may have heard Million Women study who scared many of us from giving an MHT or HRT previously, but nowadays they have some rebut on that study, and now it's relatively safe to start MHT for women with menopause who really indicated, like Farah said, right? And we would like maybe any patient who actually suitable to be started can be referred to us in the clinic. So before there's no more question here, Farah, any last word before we close the session?
Well, I hope this talk has brought up some awareness about menopause and we're more intentional when we see women in this age group so we can explore more. And that would mean we could intervene earlier if needed.
Okay, I think with that we conclude the breakfast at UMHealth for today. Since the other department who are supposed to present canceled their presentation, so I think this going to be the end of the breakfast at UMHealth for this episode. With that, thank you and have a good day, everyone.
Thank you, Prof. Thank you, everyone.